Hi guys, welcome back. The topic that we're gonna study now is Hodgkin's lymphoma. The cure rate for this condition is as much as 85%. So the main concern of the treating physician as of now is not whether the patient will be cured or not, but it is rather the worry about the side effects that can be seen with the anti-cancer drugs that we use here. So the current research in the management of this condition is mainly focused on using protocols which maintain even a higher efficacy than the one that I'm talking about, while minimizing the side effects that our patients will suffer. When it comes to the etiology of this disease, there are two important viruses which would be responsible for lymphoma genesis. One is obviously Epstein-Barr virus, the second one would be HIV. And when I say that, I also want to remind you what I have said separately, even in the discussion of AIDS, that's going to be AIDS defining cancers. There are three of them, so let's just quickly revise that also. I know the fact that you are very comfortable with Kaposi sarcoma as a AIDS defining cancer, but over and above this, HIV virus not only contributes to Hodgkin's lymphoma, but also contributes to non-Hodgkin's lymphoma. And the reason I'm discussing this is mainly to explain to you that when you study about AIDS defining cancer, it is non-Hodgkin's lymphoma that makes the cut or is included in the definition of AIDS defining cancer and not Hodgkin's lymphoma. The third one here would be invasive cervical cancer. Yes, the one that you study in gynecology related to human papilloma virus 16 and 18. The message is lymphoma genesis is primarily because of these two viruses. And if you are gonna go in for the investigational choice for this condition, I'm gonna perform a excision lymph node biopsy. Now the findings on excision lymph node biopsy is what you can see on the upper left corner of the slide, that there would be presence of classical Reed-Sternberg cells. And while I'm going to draw these Reed-Sternberg cells which have a classical owl eye appearance before you, my question to you guys, since I am very sure about the fact that you've read about this topic very thoroughly from even pathology, can you tell me the genetic aberration, which chromosomal genetic aberration is related to development of Reed-Sternberg cells? From the pathological perspective, the image would be the way it is shown. The cells would be having lots of abundant cytoplasm, and then the nucleus will most of the time be either having a cleft or will be bilobed, and inside this nucleus you would be also having a prominent nucleoli which gives it the classical owl eye appearance. Yes guys, what I asked you here before you was an overlap from pathology. The question in the exam said, with genetic aberration, which chromosomal abnormality are you familiar with that would be responsible for development of these HRS? HRS basically means Hodgkin's related, the classical one, a Reed-Sternberg cell. Well, I think you guys would have prompted this very straight away, or would have blurted out the answer straight away. Since you guys are good at pathology, that would be a defect related to chromosome number 9. The number to be remembered is 9p24.1. Now, before we go forwards, I also want to remind you another related fact. This would be with respect to owl eye appearance also being discussed with respect to cytomegalovirus. So let's just recap a question that I've discussed in the kidney section. This particular gentleman, he was suffering from end-stage renal disease. The GFR was as low as, let me say, 10 ml per minute, 1.73 meters square body surface area. So we have planned a kidney transplantation in this chap. And post kidney transplantation, there's a possibility that this person can develop a graft failure. Now, to prevent this from happening, obviously we would be giving or will be rather telling this person to be very regular with medication, especially with respect to drugs that will prevent the proliferation or growth of cytomegalovirus. But this person did not heed and did not take proper prophylactic medication, because of which the graft failure will occur. And though I've given you the answer, the way the question was framed was that this person has had a graft failure, not rejection. I repeat again, not rejection, graft failure. And the pathologist was evaluating the urine of this patient, and they would be shed renal tubular. The renal tubular cells are infected with cytomegalovirus, so they would be excreted or they would be shed in the urine of this person. So a couple of students of mine actually drew this image before me. They said, sir, what we could actually pick out was a very characteristic blue dot, which was intranuclear inclusion as well as a intracytoplasmic inclusion. The description for even this, where you have a combination of intranuclear as well as intracytoplasmic basophilic blue inclusions, is also referred as a owl eye inclusion per se. And the organism responsible for this is obviously cytomegalovirus, which I've already sensitized you, or I mentioned it initially because anyway you are familiar with that. But I just wanted to bring out the morphology per se with respect to the basophilic owli inclusions, intranuclear, intracytoplasmic aspect with respect to a post-kidney transplantation versus the owli appearance that you see on a lymph node biopsy with respect to Hodgkin's lymphoma. Chromosome number 9 aspect is anyway to be remembered, and Hodgkin's lymphoma is not a part of AIDS defining cancers is the information till now. Now, because of the overlap with pathology, he would also like to put up this aspect that is this tumor having mature B cells or immature B cells? So this is definitely a mature B cell tumor. But you see the lymph nodes which are getting filled up by the cancer cells, it's not that the whole of the lymph node is full up of Reed-Sternberg cells. Traditionally, what happens in any cancer is that one single cell will have a clonal arrest. It will not differentiate and it will keep on multiplying again and again. Like if I talk about acute lymphoblastic leukemia, the whole bone marrow will be full of lymphoblast, or acute myeloid leukemia, the bone marrow will be full of myeloblast of one particular type. But in this particular case, what happens is that these mature B cell tumor will be having a polyclonal. That's the word that I want you to remember from the MCQ perspective. It would be having a polyclonal inflammatory infiltrate, which will be composed of multiple number of cells. What I'm trying to explain to you is that Reed-Sternberg cells will definitely be present, but the percentage of those cells which are present in that bulky lymph nodes is very limited. It is rather the polyclonal inflammatory infiltrate which is responsible for development of a bulky disease and a progressive lymph node enlargement, which in this case follows anatomical boundaries, and therefore the word used in pathology is contiguous spread. I repeat the fact once again, Reed-Sternberg cells, yes, constitute one of the important components of this cellular infiltrate present, but it is not the predominant cell in the lymph node. It is rather a polyclonal inflammatory infiltrate is responsible for a lymph node enlargement. And now we will talk about what's going to happen to the clinical presentation of this patient. So you would have studied also that this disease has a bimodal age of distribution. Just like in iotics, stenosis, I have described bimodal age of distributions. In a similar way, I'm describing that this lymphoma can either be developing as early as 20 years of age, or might be developing when the person is having multiple comorbid conditions, that is at 80 years of age. That is why I was saying initially that though we have a very good cure rate for this tumor, the objective is to minimize the side effects. Now, how will it spread, or how will it initially present? So there is a possibility that when you see this patient for the first time, you might think that this person is having an extrapulmonary tuberculosis. You see, if a tuberculosis patient is going to be coughing on you, then the TB bacteria can land in your tonsils. The lymphatic drainage of the tonsils is going to be the jugulo-digastric group of lymph nodes. So no big deal, a healthcare worker or doctor could end up with a jugulo-digastric lymphadenopathy. I mean, cervical lymphadenitis is very common in India with respect to tuberculosis. So because my patient is coming with a progressive cervical lymphadenopathy, which is definitely painless at the moment, so I first thought that it could be a case of tuberculosis, but on my physical examination, I found a very characteristic pattern, or I would say a finding, that the consistency of the lymph nodes was different from what you see in tuberculosis. I think all of you are familiar with the fact that whenever it's going to be tuberculosis, it's going to be matted consistency. The lymph nodes are going to be adjacent to each other. The disease is spreading from one lymph node to another, and this matted consistency will soon evolve without treatment into a cold abscess. But in this particular case, obviously there is no abscess and it's discrete group of lymph nodes, and when you feel this, each one of these discrete lymph nodes, it's gonna be having a feel of as if it's a rubber ball. So that's one of the characteristic features. And then later on, I'll also mention a very peculiar feature of this disease, that there is pain in these lymph nodes. See, I said painless, but later on I will mention pain in the lymph nodes on alcohol consumption. That's a very peculiar statement that I'm making, and there's no plausible real explanation for this given in a medicine textbook. But yes, this feature is found that the person says that the lymph nodes have been increasing in size. Maybe he was started on anti-tubercular treatment also, and he says, sir, whenever I drink alcohol, let me say, I mean, people consume alcohol for recreational perspectives like watching a cricket match, etc. I'm not saying that he's an alcoholic, right? But he's just saying that I was watching a match with my friends and I was having a couple of beers, and then I found that there was pain in the lymph node. So I mean, that kind of a rare fact would definitely be given in the question, and subsequently the disease will spread to the higher group of lymph nodes. Now, I will call this a relatively well-behaved tumor in a sense because it respects anatomical boundaries, because you would be first having the horizontal chain of lymph nodes getting involved, then the vertical chain of lymph nodes getting involved, then the contralateral side. And when you are having a disease in the cervical group of lymph nodes, then via the lymphatic flow, like in non-Hodgkin's lymphoma, it has a hematogenous dissemination. Hodgkin's lymphoma will spread via lymphatics, and then it's going to contribute to hilar lymphadenopathy. Now, because lots of cases that diagnosis might be having a hilar lymph node enlargement, so how can an examiner portray this hilar lymphadenopathy to you would be in a sense that he will say that this person is having noisy breathing for a couple of weeks and he has been showing various physicians, that is development of stridor. In fact, as the lymph nodes will become bigger, they can also press on the superior vena cava. So this can contribute to superior vena cava syndrome. There would be congested neck veins, and in the long run, even development of collaterals, which would be sending blood downstream, because ultimately the superior vena cava has to drain into the heart, but then the superior vena cava is compressed. Another very rare fact which can develop in these patients is compression of the thoracic duct. Now, this definitely will cause a very substantial mediastinal adenopathy, but still the point is, from the discussion aspect, I need to discuss the entire profile before you. So, because the thoracic duct will be transporting chyle, so no big deal that we could be reading regarding even chylous ascites developing in these patients. And in majority of cases, when the disease is diagnosed, you would be having cervical lymphadenopathy as well as a mediastinal lymphadenopathy. Subdiaphragmatic involvement is less common in Hodgkin's. In non-Hodgkin's lymphoma, you will see me, when you go towards 50 to 60% of this video, when I discuss non-Hodgkin's lymphoma, I'll be beginning by describing that a person is mainly having lymph node enlargement in the abdomen, subdiaphragmatic. But in Hodgkin's lymphoma, in majority of cases, these age groups that I mentioned, it's mainly a above diaphragmatic presentation, by which by the time this develops, the diagnosis is already made. But let us assume the diagnosis has not been made, then what can happen? The disease can go subdiaphragmatic, and therefore there could be involvement of the lymph nodes at the porta hepatis also. Now, this is going to contribute to compression of the common bile duct, so they could be obstructive jaundice. And even if jaundice is not appearing, still one of the highlights of obstructive jaundice that I've highlighted in the liver section, pruritus, could be developing in these patients. If there is going to be retroperitoneal lymph node enlargement, now nasty things are going to occur, because retroperitoneal lymph node enlargement will kink the ureter, and therefore this person could be having a kidney involvement as well, in a sense that there would be development of hydronephrosis. So point number 3 that I'm saying is, either I would say a person who's come to medical attention very late, or maybe like he kept on changing doctors, and therefore because a proper follow-up of this patient's progressive adenopathy was not being done because of obviously change of physicians. So this guy will definitely have a bad prognosis here, because the staging of the disease will change. Then you will also read regarding category B symptoms, which can actually prompt you to initially think that you are reading a MCQ of tuberculosis. In fact, I have forewarned about tuberculosis being one of the important causes for cervical lymphadenopathy. But what I'm saying is, when you start reading this question, if he begins by saying that the person is having a cervical lymphadenopathy and a weight loss of more than 10% over the previous 6 months, then you will be tempted to first answer as tuberculosis, since it is relatively common in India. Along with this, another category B symptom, again we read with tuberculosis also, that would be night sweats. So though in India it's gonna be very hot in a summer season, so this may not be noticed, but in winter season definitely drenching night sweats would make the patient come to you, and along with this would be loss of appetite. So the examiner has a lot of scope here to present this data as that of maybe looking like a cervical tuberculous cervical lymphadenitis, though it will turn out to be Hodgkin's lymphoma. And you need to pick up those words like I mentioned: rubbery consistency, pain in the lymph nodes after alcohol congestion, mediastinal lymphadenopathy causing mass effect like these. Is you do not read tuberculosis causing such a significant mediastinal adenopathy that you would be having mass effects like the ones that I mentioned. In fact, just to remind you, you are all familiar with the word superior vena cava syndrome, right? One of the important causes for this is actually lung cancer. It is oat cell cancer of the lung, which is one of the leading causes why superior vena cava syndrome could be developing. And then this tumor might progress relatively slowly. I mean, I'll be describing Burkitt's lymphoma in the later part of the disease. Burkitt's lymphoma, which is a non-Hodgkin's lymphoma, can have a very fast progression. The tumor doubling time can be as little as 24 hours. Imagine, I mean, the tumor cells, I'm saying, I'm not saying the tumor size. I mean, I don't mean that the size of the tumor will become double every 24 hours. I mean, the cell multiplication rate is very high. And because of that, tumor lysis syndrome is also seen with Burkitt's lymphoma, whereas Hodgkin's lymphoma will have a gradual slow onset progression. And apart from this, I also want to sensitize you to the fact, though I have done this multiple times earlier, but if you are reading this video directly, without going through the earlier videos of hematology, this could definitely contribute to you pinging me. So I thought it's a good idea to just mention the fact that there's a separate chapter in volume 1 of Harrison where he talks about involuntary weight loss. If you read the word involuntary weight loss and he says, what is the magnitude of weight loss? Your answer would be 5%. Yes, guys. For category B symptoms, which are seen with hematological malignancies like Hodgkin's, non-Hodgkin's, CLL, no issues, answer it as 10%. But if he does not mention a hematological malignancy, he just says involuntary weight loss, because you see, there can be even, malignancies without hematological involvement also. No? So the cutoff is 5% over a duration of 6 months, or it is written 10 pounds. That 10 pounds may be erroneously judged by some people as 10%. Guys, it is 5% if the word plain involuntary weight, nothing else given. Forget about malignancy, hematological, non-hematological malignancy. Involuntary weight loss given, answer is 5%. But if he specifies the word category B symptom of CLL, Hodgkin's, non-Hodgkin's, no issues, your answer would be given as 10%. And along with this, another very peculiar pattern of fever might be seen, which might be even, I would say, low to moderate grade. Here what's going to happen is that this person would be having fever for, let me say, 7 days. Then the fever will come back. He will become afebrile. Then this person will again be having fever 38, maybe 38.5 for another week, and then he will again be afebrile for a week. This very peculiar pattern of fever where person has fever for 1 week, and usually the term used is unexplained fever. The pattern which we see here is that fever might be persisting for a week. It could be 2 weeks also, but then it will go down spontaneously. It's not that there was some infective pathology that you gave antibiotics. It's just that fever was present, disappeared, fever came back, again disappeared. This is what you also read as Pell-Epstein fever, which is very classical for patients of Hodgkin's lymphoma. And over and above the standard presentation of above diaphragmatic lymph node enlargement, there can also be a possibility that in the exam he can trouble you with the paraneoplastic manifestations. Every time we study any tumor, you would have noticed that paraneoplastic manifestations are also quizzed. So we are just going to draw up a very important list here, and I would like to rate point number 6 as one of the most important aspects for Hodgkin's lymphoma after the chromosomal aspects that I asked before you right in the beginning of the disease. I hope you recall chromosome 9p 24.1. That's the commonest genetic aberration that we see with respect to HRS, that is Hodgkin's Reed-Sternberg cells. Now, the paraneoplastic manifestation, the first one to be remembered would be cerebellar degeneration. So there can definitely be issues like ataxia developing in this patient. Very characteristic feature of cerebellar damages anyway, ataxia. Then this person could be having Guillain-Barré syndrome. So you could be having a ascending symmetrical flaccid paralysis. Point number 3, I've discussed in the kidney part also that Hodgkin's lymphoma can be associated with development of nephrotic syndrome. In fact, there is a special variety of nephrotic syndrome that I want you to recall, membranous glomerulopathy. When I have described membranous glomerulopathy in the kidney topic, I have highlighted that this is usually associated with solid organ tumor. And one of the solid organ tumors that I'm talking at the moment happens to be Hodgkin's lymphoma. I repeat again, which nephrotic syndrome subtype is seen with solid organ tumors? Membranous glomerulopathy, and the solid organ tumor that we're talking about here is Hodgkin's lymphoma. Then you could also be having hypercalcemia. Now, traditionally, hypercalcemia is anyway studied for a couple of other cancers. So let's just drop an important list here. I think all of you have read that squamous cell cancer of the lung can be responsible for production of PTHRP, that is parathormone related peptide, and therefore the calcium values will spike. Then I'm not talking about hyperparathyroidism at the moment. What I'm talking about is malignancies which can be related to hypercalcemia. So the second important one would be breast cancer. And then another hematological lesion which has been discussed in the app separately in hematology is multiple myeloma, where we have studied recording features of CRAF. So what I've just tried to do here is talk about a couple of aspects or cancers where hypercalcemia is seen, and a important one in the list, which I would say important from the exam perspective, is even Hodgkin's lymphoma. And then these patients could be having immune mediated anemia as well as thrombocytopenia. Anyway, I would say that anemia and thrombocytopenia can be present in any hematological malignancy. But when I say immune mediated, the first time I have described immune mediated hemolytic anemia, autoimmune hemolytic anemia, was for CLL, the first video in the hematology section. This is the second time that I'm highlighting regarding immune mediated. See, if a disease will progress to bone marrow, Hodgkin's lymphoma is a disease starting from lymph nodes, it can go to the bone marrow, it can colonize all of the bone marrow, then anyway cytopenia is seen. So disease progression causes cytopenia, but immune mediated cell counts becoming lesser is what you read with chronic lymphocytic leukemia and even with Hodgkin's lymphoma. I shall now be describing regarding how would I be working up this patient with the combination of cervical and a mediastinal lymphadenopathy. Just like any hematology case, I'll be doing a complete blood count and also would be checking out the LDH values of these patients. In fact, LDH I'll be discussing even with respect to the prognostic index. We have an international prognostic index. It's a software in which we can put in the values of various parameters. I will tell you the values also, but LDH is one of them that has to be remembered from the prognosis perspective. Now, if he says what imaging modality is good for evaluating a person of Hodgkin's lymphoma, then the imaging modality which is accurate is PET-CT. PET-CT will not only help you in identifying the disease focus, but it will also help you in staging, because I'll be talking about Ann Arbor classification for staging the disease, because in any malignancy, I mean, proportional to the severity of the disease, we would like to go in for treatment. Like early onset disease, Hodgkin's, will be preferring a radiotherapy. In the later part of the disease, we'll be using chemotherapy like ABVD protocol. So PET-CT is gonna pick up the disease focus and would also be good for the staging component. Now let us assume that the facility is not available. I would still be using then a CT chest and a CT abdomen. That would obviously mean a lot of radiation exposure to this person, but I want to stage the disease per se. The investigation of choice, I repeat once again, if he says in the question what imaging modality is to be used for diagnosis of these patients, then PET-CT, because not only it will pick up the disease focus but staging component also. But if he just says the word investigation of choice, then I have said right in the beginning of the discussion that we would like to go in for a excision lymph node biopsy. And when I start talking about excision lymph node biopsy, the query in your mind will be obviously, sir, when will you discuss regarding the WHO modified real classification? So yes, I'm gonna definitely do it. But at the moment, my focus would be to talk about two aspects. One is gonna be the Ann Arbor classification for clinical staging. And second would be to talk about that I'm gonna send this lymph node sample for flow cytometric analysis. And let's look at what the flow cytometric report says. It will say CD15 and CD30 positivity. I'm going to describe a Hodgkin's lymphoma to you that will also be CD15 and 30 negative. But when it comes to classical Hodgkin's lymphoma, 95% of Hodgkin's lymphoma, you will always see the word written small c HL. That means classical variety. In classical variety, CD15 and 30 would be positive. And if I say non-classical variety or the atypical variety, if I say non-classical atypical, it's going to be CD15 and 30 negative. Since it's a B cell tumor, we expect that CD19 and 20 should be expressed, and even PAX5. I want to tell you the fact that CD19 and 20, because it's a B cell tumor, I said it's a mature B cell tumor, traditionally it should be present, but then this is what we read, that there is usually a low expression, or he might say no expression of CD19 and 20. It's after all a tumor cell, no? So traditional markers are either having a low expression or there's a no expression of them, and PAX5 positivity would be present. So anyway, I mean, these terms you are familiar from your pathological domain also, CD15, 30 positivity, PAX5 positivity from immunohistochemistry. But I just thought that I should definitely reinforce this information. Since the chest of this patient is involved, I can go in for a baseline pulmonary function testing. happening. And why am I doing 6 and 7 is not only that I want to check out the baseline status, because this disease can occur in very old people, 80-year-old man. So I want to see the lung status and the cardiac status of a patient from the perspective that my chemotherapy might actually worsen this patient. Like one of the drugs that we'll be using for management of these patients can be cardiotoxic also. So I want to see whether my person is fit enough to even receive, in case of advanced disease, a full course of chemotherapy. There are 6 cycles only, but still I need to check out the fitness levels of the patient. I will also be ordering an infection panel. Why? Because I want to go into the etiology behind why this is happening. I mean, Epstein-Barr virus, HIV is what I'm looking for. And I have already emphasized, I'll say that fact once again, Hodgkin's lymphoma is not included as a part of AIDS defining malignancy. Now let's look at the Ann Arbor classification. Let's work out the data here so that if he wants to put up a question on the staging, you should be able to answer the treatment proportional to the stage. Because if it's going to be advanced disease, I'll tell you what is meaning the word advanced disease. We'll go in for chemo. If it's going to be early part of the disease, stage 1, like then we can go for radiation. Now, stage 1 here would basically mean that this would be a single group of lymph node that can be involved in a patient. Like there could be a, let me say a horizontal and the vertical chain of the left side of the neck of this patient, the cervical group of lymph nodes are enlarged. Then he also says instead of this, even other lymphoid tissues can also be involved. So when he says or lymphoid tissues, you should know like what kind of lymphoid tissues is he talking about. He's talking about origin of the disease in the spleen, or it might be originating even in the thymus. So the language to be remembered by you would be a single lymph node area or any other lymphoid tissue as well. In stage 2, it's very easy to remember at least minimum 2 group of lymph nodes. The highlight of these involvement of 2 group of lymph nodes is what I would like to point to this diagram where I'm putting the number 2. You can see that on one side, on the same side of the diaphragm, basically, if you look at the black representations, I have shown here is a cervical adenopathy as well as a mediastinal adenopathy just adjacent to the heart of this patient in the hilar area. So what I'm saying is in stage 2, it is 2 group of lymph nodes that are involved, but both of them would be present on the same side of the diaphragm. And this obviously a CT can definitely tell you. So I said a CT or a PET CT, whichever is available, can be done. But if you read about stage 3, it would still be more than 2 group of lymph nodes, but it would be on the both sides of the diaphragm. And now, in fact, you can see in stage 3, there is a below diaphragmatic involvement that is also occurring. So if I put a 3 here, you will notice what I have shown here is involvement of lymph nodes that is mediastinal. Then even in the spleen and even a retroperitoneal group of lymph nodes, you can see the big blood vessels, right? The inferior vena cava, the aorta. So there's a retroperitoneal lymph nodes also. But at this moment, they are present on both sides of the diaphragm. So that would be stage 3. And when you say stage 4, your answer would be, this would be a extranodal extension of the disease. Extranodal extension, the common ones that we'll encounter will be like the liver or even the bone marrow of this patient. So the cancer has disseminated to the bone marrow. You see, in leukemia, the cancer begins in the bone marrow and goes to lymph nodes. Here, the tumor started in the lymph nodes and has now gone into the bone marrow, and therefore cytopenia can be seen. Along with this, you will also notice in the books, it would be written like 4A or 2A, 2B stage. So let's look at what do you mean by the word 2A or 2B, or let me say 3A or 3B. B here means the category B symptoms that I was describing. Category B symptoms, I'm going to make you practice once again weight loss of at least more than 10% over a duration of 6 months. Or another category B symptom can be presence of persistent fever in a patient. Right? This fever will persist for a few days, then will go down on its own without any usage of any antibiotics. So I can say unexplained fever. And then can be drenching night sweats. So if you are gonna be having any of these, I decided to write them again so that I can just emphasize on the fact that if any one of these are not described, if any one of these that are described in point number B are not described, you will say it is 2A. 2A would be like this chap. Let's look at this particular image. 2A would be meaning that the person is having a cervical lymphadenopathy, a hilar lymphadenopathy on same side of the diaphragm, but there are no category B symptoms. If the person, you need a detailed history obviously for that, but if you are having the same patient, or let me say another patient who's having category B symptoms which I've just written before you, you will say it is stage 2B. That's it. And then you will also read sometimes written as 2E or 3E. So let's look at what he means by the word extra lymphatic. Now this is important because earlier I was using the word extranodal, right? I was using the word extranodal, but now I'm using the word extra lymphatic site. So by extra lymphatic site, he says any site excluding the liver and the bone marrow. I repeat the fact, if liver and bone marrow are involved, you will say it is stage 4. If any site apart from liver or bone marrow is involved, then you're gonna say, like for example, 2 at stage 2 only, there is an involvement of any other site apart from liver or bone marrow, you will say 2E. So these are the terms, though, you know, in lots of classifications, there's also an X written, that is for extensive disease, but I'm not going to X because that is not given in Harrison. In Harrison, they've just mentioned A, B, and E. A means no category B symptoms, B means obviously what I've described, and E would mean extra lymphatic side, but it must exclude. That's the word to be remembered because this can be put up in a question. It is excluding the liver and the bone marrow. If it's a bone marrow involvement, straight away that means this would be stage 4. So my objective was to teach you regarding Ann Arbor classification here. And let's just from, I would say, a final year perspective, look at the differential diagnosis. I mean, though the diagnosis has been made in this case because I could find on excision lymph node biopsy classical Reed-Sternberg cells, I was able to identify the polyclonal inflammatory infiltrate, but still in the exam, because from a final year perspective, they give you a case of Hodgkin's lymphoma, they can ask you, okay, what are the differential diagnoses that you would be considering in any chap from presenting with a cervical and maybe a mediastinal lymphadenopathy. So tuberculosis has anyway been ruled out. So apart from this, you anyway need to consider infectious mononucleosis. Even that can be present in young adults. It's also called as Kissing's disease. Non-Hodgkin's lymphoma is one of them. Then you must ask for any history of patient having tendency to have recurrent episodes of seizures, because in epilepsy, if you are using phenytoin, nowadays we obviously use, for most of the epilepsies we use lamotrigine, but still you will see in government supply phenytoin is available, and phenytoin itself on long-term usage can contribute to a substantial lymphadenopathy. And if it is not, then especially in I would say older age group, non-lymphomatous malignancies must be considered, because after all, you see, you have to take up the patient in total. Totality, there might be a cancer which might be originating from the GIE, and it might be going to, like I'm talking about Virchow's node involvement, right? So that's going to be a Trizer sign developing. So non-lymphomatous malignancies anyway to be considered. This is the information that I've written in green is mainly from the final year perspective. I mean, after all, in actual competitive exam, he will be more bothered about asking you regarding the imaging modality, the investigational choice, aspects related to difference between stage 4 versus, let me say, 2E. 2E would mean extra lymphatic site, which is apart from liver or a bone marrow, as I've explained to you. So those are the kind of aspects which they will love to ask. And before I go into the treatment part, I will anyway cover the pathological domain also. So let's do a quick recap from the pathological perspective for WHO modified real classification, that is the revised European and the American League classification. So what I'll do here is just jot down the important names that would be remembered by you from your pathology days. That's gonna be nodular sclerosis. Then in India, what you have is relatively more common is mixed cellularity, though I'll also tell you a small controversy between Robbins and Harrison here. Then is lymphocyte rich variety. There is a high probability that lymphocyte rich can easily be confused or mixed up with lymphocytic predominant variety. The ones that I have written before you at the moment would be written in the textbook as CHL, that is the classical variety of Hodgkin's lymphoma. In fact, 95% of classical Hodgkin's lymphoma will mainly be these two, nodular sclerosis and the mixed cellularity variety. But then we also have what is the non-classical one, or also the atypical variety, which will be having the traditional popcorn cells. Yes, you all are familiar with that, nodular lymphocytic predominant Hodgkin's lymphoma. So because of the longish name, I thought I'll just mention the entire detail here. By dotted line, I just want to imply that why the last one that I have written here before you is important from the exam perspective is because this will not be having the standard CD15 and 30 positivity, rather it will say CD15 and 30 negative. CD19 and 20 will be relatively better expressed here. You notice that when I was describing the classical variety, even in the earlier part, I said CD19-20 might be having a low or a no expression, but here the expression would be present. Then would be CD45, which is anyway leukocyte common antigen, and CD79A. So flow cytometric markers are anyway a good way to identify. Over and above the presence of popcorn cells, well, popcorn cells are gonna be variants of Reed-Sternberg cell only. The alternative name for these would be L and H cells. And when you read about L and H cell, it is lymphocyte and the histiocyte cell only. So that's an alternative term for a popcorn cell. The nodular sclerosis is anyway the most common variety, and the cell which is present here is a variant of Reed-Sternberg cell, which would be called as Lackiner variant. It is the mixed cellularity that is more common in India, and this would be having classical Reed-Sternberg cell, which I showed in the starting of the discussion. And now the controversy is with respect to, and don't give too much of importance to it. I mean, a lot of guys, they say, sir, I mean, in pathology, another thing is mentioned. See, in Harrison, actually, it is mentioned that in HIV positive patients, you can have mixed cellularity as well as lymphocyte depleted. I want to tell you that in Robbins, you would have noticed that lymphocyte depleted variety is associated with HIV. But I said in Harrison, first it is written a mixed cellularity for HIV, and after that is written lymphocyte depleted. Now this could definitely be, you know, between two big guns, there is a fight. So let's not get involved in that. And I would suggest you to follow the Harrison data. And per se, controversial questions, at least for last couple of 3 to 4 years, I have not seen any significant controversial questions being asked. So what I mentioned here before you is WHO modified real classification. And this nodular lymphocytic predominant variety is extremely slow growing. I mean, it obviously can progress, no doubt about it. Any tumor can progress, but then this might take a relatively long time to progress. So as compared to other tumors, this is, I would say, having an indolent presentation. And after that, I'm saying a very surprising statement. Nodular lymphocytic predominant variety might transform to diffuse large B-cell lymphoma. If you have listened to my discussion of chronic lymphocytic leukemia, I have mentioned it might turn aggressive into DLBCL. I used the term there, Richter syndrome. So at the moment, I'm not describing Richter syndrome, but I just want to tell you that in the hematology discussion, it is 2 times when I have described that a particular tumor, let's call it X, is gonna get converted into DLBCL. The first time we discussed that was CLL, Richter syndrome. And now I wanna tell you that nodular lymphocytic predominant variety might also get transformed into a diffuse large B-cell lymphoma. I will be telling you the treatment also in the subsequent slides with respect to what will you do if it gets transformed into an aggressive format. I mean, what's the chemotherapy which is to be used. As far as the popcorn cell information is concerned, I think everybody remembers if he says popcorn with respect to a chest x-ray, we are talking about a benign tumor in the lungs. That's going to be pulmonary hamartoma. If he talks about a popcorn on a mammography, you are anyway comfortable that we are talking about a breast mouse, the benign tumor of the breast, that's going to be fibroadenoma. So once we have done this revision from, I would say, a couple of aspects from pathology, we'll next talk about what is the treatment that's going to be offered to these patients. From the treatment perspective, the answer will depend upon whether it is a localized disease or whether it is an advanced disease. If it's going to be localized, I will be giving chemotherapy to this patient, but along with this, even a radiotherapy will be given. So this is anyway radiosensitive tumor. We'll be giving field radiation to these patients, though there can be disadvantages also. One of the disadvantages can be that when you give radiotherapy to the chest, there can be development or damage to the myocardium. So there could be cardiomyopathy that could be developing. Another possibility can be that if you have given, let me say, field radiation to the neck area, in an old man, it can contribute to worsening of the atherosclerosis in the carotid artery, and as a result of it, atherosclerotic plaque might actually get ruptured, and the fragments from that might go to the brain and might contribute to development of stroke. So the side effects of radiotherapy are anyway to be considered considering the age group of the patient. So I've written plus minus. But if it is advanced disease, then it's beyond radiotherapy. The only thing that will be helping this patient would be the ABVD protocol. And what you can do next is just revise the side effects from the pharmacological perspective, because adriamycin anyway can contribute to damage to the heart. Bleomycin can contribute to pulmonary fibrosis. You are all aware of the side effects from pharmacology. Alphabet V would be standing here not for vincristine but for vinblasting. And alphabet D, I find a lot of doctors casually answering for alphabet D as doxorubicin. I mean, that same as adriamycin. So this is going to be dacarbazine. And this is the standard chemotherapy that is useful for these patients. Another protocol which is available for these patients is called as Stanford V regimen, and another one is called as BCOG, which I have not written because mostly in the exam either of these two names would be used. Either it would be ABVD or it would be a Stanford V regimen, which would be recommended for these patients. Now, there is also possibility that you have given multiple cycles of ABVD and the person initially showed an improvement, but then there is a relapse of Hodgkin's lymphoma. If there's a relapse of Hodgkin's lymphoma, there are two treatments available. First, I would like to focus regarding the second one, that is autologous bone marrow transplantation. This is the second time in hematology discussion that I'm talking about autologous bone marrow transplantation. And apart from this, we also have another drug available. So another monoclonal antibody being added to your vocabulary, that is brentuximab. So mostly in the exam, it's unlikely that he'll talk about one. It's mainly the two aspect which I want you to remember, because traditionally we read always about a allogenic bone marrow transplantation. As far as the prognosis of these patients are concerned, there is an international prognostic score index available. Now, we'll not get into the formula behind it. I'll just mention some of the parameters of this international prognostic index. And you will notice that some of the parameters that are right here before you are different from the ones that I'll be describing for non-Hodgkin's lymphoma. So international prognostic index is a scoring index that will tell you regarding the chances of survival of these patients, and I would say from the patient's perspective, quality of life and how long will he live. So this is an online calculator. What you will do is feed in the age of the patient, gender of the patient. Then would be values of lactate dehydrogenase. I told you in the earlier part of the discussion that LDH has prognostic values also. Some lab reports will also be entered, like hemoglobin, then is albumin, then is total leukocyte count, and then is also the lymphocyte count of this patient. So when I feed in all the values, the computer will tell me the survival rate for these patients. And in majority of cases, I have told you almost more than 85% of the cases we can cure the disease, and it's the side effects with the drugs that we are trying to minimize. Though this is the standard regimen which is being used ever since I was a student, and I'm teaching you today also. So I would say fairly safe, but yeah, as physicians we always love to evolve. We try to do better for our patients. So that's why I made that remark that okay, we are looking for better options for management of these patients. And one of the disadvantages of radiation I've already sensitized to you to, that could be even acceleration of the atherosclerotic lesions present in both the heart as well as in the carotid artery of the patient. Now before I start with non-Hodgkin's lymphoma, I would just like to spend about a minute or so on making you revise regarding nodular lymphocytic predominant Hodgkin's lymphoma. I mean, do remember the word predominant is different from the word lymphocyte rich, and what you get here is presence of L and H cells, which are called as lymphocyte and histiocyte cells. The alternative name for these would be popcorn cells. Another aspect that I've highlighted is that this tumor would be CD15 and 30 negative, whereas when it comes to the classical variety, it would be CD15 and 30 positivity. The bad news is this can definitely transform into a diffuse large B-cell lymphoma, just like I have described even for a chronic lymphocytic leukemia. And now you will notice why am I discussing it again. He has mentioned that if the disease is showing a progression, like on a PET CT, if it is showing a progression, there are two strategies that we can be using for these patients. One is obviously radiotherapy for any tumor which is having, especially Hodgkin's lymphoma, where the lymph node is causing a mass effect. For me to shrink the size of the lymph node, I can give radiotherapy. but I can also be using chemotherapy for these patients. Now both ABVD as well as R-CHOP has been used for management of these patients, and you are picking up what I am trying to say before you, that traditionally in Hodgkin's lymphoma, the chemotherapy I taught you was ABVD. But look at the surprising thing that I'm teaching you right towards the end of the topic of Hodgkin's lymphoma is that R-CHOP, which you always read in non-Hodgkin's lymphoma, is one therapy that has been shown to be curative for management of nodular lymphocytic predominant Hodgkin's lymphoma. I reiterate this statement. The topic we are studying is Hodgkin's lymphoma. The chemotherapy that we study for it is ABVD and Stanford, and I have taught you R-CHOP, which is useful for non-Hodgkin's lymphoma, being used with high success rate for nodular lymphocytic predominant Hodgkin's lymphoma. So the question will deliberately be like this: in which variety of Hodgkin's lymphoma R-CHOP will be used? Your answer will be the what I have highlighted, I mean nodular lymphocytic predominant Hodgkin's lymphoma. Coming to the etiology of non-Hodgkin's lymphoma, first I'll talk about the viruses which are responsible. Those are gonna be Epstein-Barr virus and HIV. That's common with Hodgkin's. But then you need to remember a couple of aspects over and above for non-Hodgkin's lymphoma. The first one is STLV1. This is responsible for development of a disease that is adult T-cell lymphoma, and this would be a precursor of a disease that was discussed even in acute lymphoblastic leukemia by me. The name was adult T-cell leukemia. I'll repeat the facts once again. I have taught you in one of my earlier classes in acute lymphoblastic leukemia that STLV1 causes tropical spastic paraparesis, and adult T-cell leukemia, today I've told you a precursor of this adult T-cell leukemia as well. For adult T-cell leukemia, the highlight was that the lymphocytes which are present here, the nucleus of this would be definitely I would say lobulated, and the way I've drawn it before you, it would either be referred to as a flower cell or would be referred as even clover leaf pattern. Now after HTLV1, the next one to be remembered is HHV8. Nowadays we don't read the term HHV8. You have already read in HIV topic that HHV8 is responsible for development of Kaposi sarcoma. So nowadays you will notice it being referred as KHSV, that is Kaposi then herpes simplex virus. And the reason why I'm discussing at the moment is that this is associated with development of a rare non-Hodgkin's lymphoma, that is primary effusion lymphoma. Important aspect to be remembered. Then additional fact here also, HHV8 is also responsible for pathogenesis of Castleman disease. This was actually an image-based question on Castleman disease that was asked in the recent years. You are aware of a very classical appearance present here that is called as a onion skin appearance. So I will show you the histopathological image that was asked on the subsequent slide. But at the moment what I've said is HHV8 former name, current name is Kaposi herpes simplex virus, is responsible for Kaposi sarcoma, primary effusion lymphoma, which is a subtype of non-Hodgkin's lymphoma, and even development of Castleman disease. The data that I am writing at the moment before you is specific for non-Hodgkin's. Rest are some allied details which are also being introduced. Then is hepatitis C virus. Now, which kind of non-Hodgkin's lymphoma will be associated here is the objective of our discussion. I mean, this is what they teach you in pathology, and I'm discussing here also before you. That would be lymphoplasmacytic lymphoma. So you just need to get familiar with the names, because majority of questions on non-Hodgkin's lymphoma will be with respect to etiology perspective only. It's very unlikely that they'll give you a clinical presentation of non-Hodgkin's, though I'll cover that also. Now you will notice that every time I have described a tumor, both Hodgkin's and non-Hodgkin's, I've spoken about viruses. So I'm now going to be incorporating a bacteria in the discussion, that is Helicobacter pylori. And H. pylori is responsible for a tumor in the stomach that would be called as multoma, mucosa associated lymphoid tumor. Though yes, they can also ask you about the chromosomal swap which is associated with development of multoma, that is 11:18, but then the traditional information of H. pylori contributing to gastric multoma can definitely be incorporated. Let's now talk about chromosomal swaps that are responsible for non-Hodgkin's. The number to be remembered would be T14:18. This is overall the most common chromosomal translocation which is involved in pathogenesis of non-Hodgkin's lymphoma. Apart from this, another chromosomal translocation on the agenda would be 11:14. This would be responsible for mantle cell lymphoma. And how to differentiate mantle cell lymphoma from chronic lymphocytic leukemia, I have discussed that in the CLL topic. There are a couple of flow cytometric markers that I have talked about for CLL in comparison with mantle cell lymphoma. So if you want to solve MCQ mantle cell lymphoma, you need to actually go back to the discussion of CLL, and it's not to be solved on clinical presentation, but it is to be solved on the basis of flow cytometric presentation. Now, once we've remembered the etiology per se, I'll just mention the list once again, because I was talking about a couple of accessory facts also. It is Epstein-Barr virus and HIV, which are common. Then is HTLV1, then is Kaposi, herpes simplex virus, then HCV, H. pylori, and the chromosomal swabs. The numbers are 11, 18, 14, 18, and 11, 14. Getting used to the numbers is very much important. And Epstein-Barr virus, you have studied actually so many times that one starts wondering that, okay, why should I not compile a list? Because this is definitely gonna be related to nasopharyngeal cancer, but I am today talking about hematological perspective, or I would say pure medicine perspective. So you very well know this is related to development of a very aggressive non-Hodgkin's lymphoma that is found in African children, that is Burkitt's lymphoma. The slide of this also I will show to you, apart from the slide of Castleman disease, which is still in pending. Epstein-Barr virus has also been documented to contribute to development of post-solid organ transplantation lymphoma. Do remember my words. In the starting of this discussion, I have talked about graft failure, that is solid organ transplantation. Kidney transplantation was done, graft failure occurred, that was cytomegalovirus. But if they change the question to solid organ transplantation, not a graft failure, but a solid organ transplantation is followed by a lymphoma development, the organism responsible is not cytomegalovirus, it is Epstein-Barr virus. This is anyway responsible for the commonest histopathological subtype of non-Hodgkin's lymphoma, that is diffuse large B-cell lymphoma. This is responsible for Hodgkin's, as we discussed in the beginning of the discussion. And one more entry worth its weight, worth its important in multiple choice questions would be that Epstein-Barr virus plays a role in development of extranodal natural killer cell T-cell lymphoma. So I've just compiled a list before you from hematology perspective for when should you remember Epstein-Barr virus, with at least one important aspect which highlighted what I have seen a lot of guys casually answering is solid organ graft failure versus solid organ transplantation followed by lymphoma. Both things getting mixed up in a pressure cooker situation in the exam and the questions going wrong. So you can very well see that a lot of these things are discussed in pathology, but it ate up entire one slide of mine, though I did not plan to describe all of these, but then I thought later on while discussing the topic that it's a good idea to compile a list at a single place for a ready reference. And now would be to talk about two histopathological aspects which are pending from this slide. So let's move on to the subsequent one where I demonstrate them before you. When it comes to Burkitt's lymphoma, when you are gonna do a lymph node biopsy, the very classical presentation will be present, and you can see, you will be able to see sheets of blue cells, basophilic nucleus, basophilic cytoplasm, but in between that there are a couple of white spots present, and this is referred as a starry sky appearance. So very standard question that you encounter. Starry sky appearance with respect to a CT head is obviously neurocysticercosis, but here I'm talking about Burkitt's lymphoma. And then another aspect which I've highlighted here would be a concentric. You can see I would say mononuclear cell infiltrate, but it is arranged in a very concentric fashion. This slide that is currently shown was the exact, almost very close to the exact slide that my students hand drew before me after the exam. This was Castleman syndrome. This also presents as lymph node enlargement. You will be doing excision lymph node biopsy, and you would be having this onion ring appearance. And you very well know when I say the word, I would say onion skin appearance, you read about this with the Ewing sarcoma, then you read it in primary biliary cholangitis, primary sclerosing cholangitis. So definitely, I mean, the onion skinning again has a lot of importance from the classical name being asked in the exam. Now, once we're through with this, some aspects of Burkitt's lymphoma to be added here. These are chromosomal swabs. I'm going to write 3 of them before you. 814, 28 and 822. Can you comment on which of these is the commonest one? Yes guys, it's 814 which is relatively the more common one, though any of them could be responsible. And then we also read about overexpression of a proto-oncogene in these patients. So the chromosome which is involved here is 8q24, which will result in overexpression of CMYC. And when I say overexpression, I'm just putting plus marks to say overexpression of CMYC. What it will do is that it will contribute to uncontrolled mitosis of cells, and apoptosis will be inhibited. So cancer will be created because cancer cells are gonna keep on multiplying again and again, and they will usually not die. And most of the time, the description given will be of an African child, and he would be having a classical, very prominent jaw swelling. That's a standard image which is given in Robbins. So when it comes to Burkitt's lymphoma, I think that the aspects to be remembered would be the ones which are present on the slide at the moment. And next we'll talk about how would non-Hodgkin's lymphoma present in adult, because in pediatric presentation, yes, it's Burkitt's lymphoma that would be asked. Overall, the commonest histopathological subtype that we will encounter will be diffuse large B-cell lymphoma. This is more common as compared to a follicular lymphoma. The chromosomal swap which is responsible for the follicular lymphoma should be remembered as 14:18. So a lot of numbers coming up here. And for diffuse large B-cell lymphoma, already sensitized you to the fact that this is one of the common tumors that is seen with HIV. AIDS defining cancer is anyway associated with Epstein-Barr virus as well. So majority of these aspects which I have highlighted in this particular discussion are mainly from pathology. So let's make the discussion more clinical by now focusing on the clinical presentation of the patient. Non-Hodgkin's lymphoma will be having a bad prognosis. It will be having a hematogenous spread. It will be having a non-contiguous spread. It will not respect anatomical boundaries, and most of the cases present with a subdiaphragmatic lymphadenopathy. So my patient is having progressive abdominal lymph node enlargement, and how would he come to know that he is having this? He might actually be admitted into a surgical emergency with development of intestinal obstruction. Look at the extreme amount of lymphadenopathy that I'm talking about, that it can produce a mass effect and can cause an intestinal obstruction. Apart from this, other myriad presentations could be development of ascites, and if it's going to be retroperitoneal lymph node enlargement, then it can kink the ureter, and he might be seeing a urology department because a specialist in the urology department because he's ended up with development of hydronephrosis. In fact, there is also possibility that non-Hodgkin's lymphoma can present as a testicular lump. The last time I described a testicular lump was with acute lymphoblastic leukemia. So ALL, AML can anyway have I would say a testicular presentation, but even non-Hodgkin's lymphoma can be presenting as testicular involvement as well. So that's a very minor point, but has to be remembered, and was asked in November 2021 INISET exam. They mentioned about a man who was having a testicular mass, old man with a testicular mass, and along with that he was having cerebellar ataxia also. So that was a paraneoplastic manifestation. But yes, the bottom line is testicular involvement is one of the clinical presentations of non-Hodgkin's lymphoma, is what you need to remember. From the pediatric perspective, he will mainly describe regarding jaw swelling. I mean, it can be present in adults also, but I said if he describes an Afro-American child or just mentions about African child, then this is to be considered. Then this tumor can also exhibit a meningeal spread. So your patient could be having features of raised ICP or even a meningismus. The first time I described that a blood cancer patient is having meningismus was for acute lymphoblastic leukemia. In fact, lumbar puncture will be required to demonstrate that the person is having a spread of the tumor to the brain and especially to the meninges. Acute lymphoblastic leukemia, acute myeloid leukemia, in fact, all cancers can actually contribute to a CSF spread except one, that is Hodgkin's lymphoma. And the question asked in the exam was that lumbar puncture for determining the presence of malignant cells will be required in all hematological malignancies except. The answer would be Hodgkin's, because Hodgkin's will anyway be having a lymphatic dissemination. We are talking about cancers which are having a hematogenous dissemination, so they can definitely erode into or can cause a CSF involvement as well. Then category B symptoms can be described. This will definitely ensure that the examiner can waste some of your time, because you would be thinking in terms of tuberculosis, but then tuberculosis of the abdomen having a mediastinal adenopathy is very rare. In fact, the usual presentation would be ileocecal involvement contributing to a stricture and features of subacute intestinal involvement, a subacute intestinal obstruction primarily. Then as the disease will progress, even bone marrow involvement will occur. I'm not talking about immune mediated hemolytic anemia anymore. I am saying the disease has spread to the bone marrow from the lymph nodes, and therefore cytopenias will start developing in the patient. So progressive pallor and bleeding, which could be in the form of epistaxis and bruises. The bad news is this tumor can even contribute to spinal cord compression. I mean, that's again a rare fact, like I was talking about testicular involvement in these patients. I want you to remember that the lymph nodes which are present retroperitoneally, they could actually be pressing on the nerve roots, and then subsequently, I mean, spinal cord compression like features could be developing, and even cranial palsies have been described in these patients. I mean, the lymph nodes at the base of the skull which are involved by this cancer can contribute to cranial palsies also. The paraneoplastic manifestation that I've described with Hodgkin's lymphoma before you was cerebellar degeneration and Guillain-Barré syndrome. I just thought I'll just remind you once again, because I was talking about spinal cord involvement here. So do remember this fact. I'll reiterate. I spoke about neurological manifestations developing. The neurological manifestations were even discussed in Hodgkin's lymphoma with respect to cerebellar degeneration, and GBS have said those points 2 times. Apart from this, an additional aspect which I'm using a separate color to highlight, and why this is because this is very peculiar to non-Hodgkin's lymphoma, Waldeyer's ring involvement. Though in, I would say, Harrison, Waldeyer ring is even mentioned in Ann Arbor classification for even Hodgkin's lymphoma. But traditionally, Waldeyer ring involvement, that means a tonsillar enlargement, that could be tubal tonsil involvement, and therefore the manifestations, I mean, how would a patient come to know that he has some issues? They can be loud snoring, they could be obstructive sleep apnea like manifestations developing in a patient, and if it's gonna be mycosis fungoides, the tumor will originate from the skin. We are talking about cutaneous T-cell lymphoma. So you could even be having extreme redness and pruritic lesions. I mean, initially the person might think that he's having atopic dermatitis. He might be going to a dermatologist for treatment for atopic dermatitis, but gradually the lesions will keep on increasing, and almost 90% of the body skin of this person would be involved with extensive amount of redness present. That is erythroderma. You will read about erythroderma with respect to cutaneous T-cell tumor, that is mycosis fungoides followed by Sézary syndrome, and in my subsequent slide I will explain to you the difference between the term mycosis fungoides and Sézary syndrome as well. These are a couple of important clinical manifestations that would be present for non-Hodgkin's lymphoma, with 7 and 8, which are, I would say, good pickup points. Like I described in Hodgkin's lymphoma, term like Pell-Epstein fever. You don't read about Pell-Epstein fever anywhere. Similarly, Waldeyer ring involvement, erythroderma, and couple of other aspects also. Like I said, below diaphragmatic lymph node enlargement are some of the pointers which will make you think that we are talking about a lymphoma genesis or a lymphoid malignancy. And now we will talk about workup of these patients, and then subsequently the WHO modified real classification. So what are the tests that I'll be doing? Initial tests that I'll write will be standard. I'll be ordering a complete blood count and LDH. Yes, LDH is a prognostic marker in both Hodgkin's and non-Hodgkin's lymphoma, and we'll talk about international prognostic index also, but there will be subtle differences with respect to what I said for Hodgkin's versus the parameters for in international prognostic index for non-Hodgkin's lymphoma, so watch out for those. The imaging modality for disease activity, I mean, if I want to find that has non-Hodgkin's lymphoma disseminated enough to the bone marrow of the patient, then I don't need to do a bone marrow biopsy. In fact, that's a very powerful statement given in Harrison. He says, instead of doing a bone marrow biopsy to demonstrate, because when you're doing a bone marrow biopsy, you might miss that area. I mean, the site that you are putting in the needle may not have had a complete, I would say, colonization by the cells that came from the lymph node. So you might get a false negative report, but if you rely on technology, you will be in a better position to identify the disease activity has reached from the lymph nodes to even the bone marrow of the patient. So PET-CT for not only the staging, but even to pick up that the disease has disseminated. And indirectly, I would say that when I say disease activity, the disease activity spreading, it obviously means that the staging of the person will keep on deteriorating, and or the same kind of classification will be used in these patients also for clinical staging. Then if there are neurological manifestations, I'll be doing a MRI spine in the patient, because I said lymph nodes could be pressing on the nerve roots. FISH will help me pick up those chromosomal translocations I was talking about, 11, 18, 14, 18. The numbers anyway, you will have to put effort to remember, and the ones that I mentioned even with the Burkitt's lymphoma. The investigational choice remains the same, excision lymph node biopsy. Along with, I can also go in for a flow cytometric analysis in these patients. Next, I'll be describing a overlap from pathology, that is aspects related to WHO modified real classification, that is revised European and American League classification. So non-Hodgkin's lymphoma will predominantly be a B cell tumor, and some of them can be a T cell tumor also, unlike Hodgkin's lymphoma that was a pure mature B cell tumor. So let's just jot down for practice sake the subtypes once again. Diffuse large B cell lymphoma is the commonest one, related to HIV and Epstein-Barr virus. Why I'm repeating that again is because you will notice that in some MCQs he will be talking about immunoblastic subtype of diffuse large B cell lymphoma. I want to reiterate this statement. The question said in HIV positive patients, the AIDS defining malignancy that would be present would be which of the following, and DLBCL was not given the options. This is what I have taught you right in the starting of the discussion itself, that AIDS defining cancer is going to be diffuse large B cell lymphoma, but a couple of students, they after the exam told me, sir, DLBCL was not in the options. So there's a subtype of DLBCL that is called as immunoblastic subtype. That's the answer to be given, provided DLBCL is not given. Then we have already spoken about Burkitt's lymphoma. The chromosomal swaps all have number 8 coming up again and again. That would be 814, then would be 822, then would be 28. And I also spoke about CMYC overexpression that inhibits apoptosis in these patients. Then is gastric maltoma, that would be related to Helicobacter pylori. And the one that is related to hepatitis C, I mean, traditionally with hepatitis C, we do read about extrahepatic manifestations, but to read about a lymphoma is again very peculiar aspect. So because of, I would say, less common importance being given to this data, the examiner has put up questions like these. Lymphoplasmacytic lymphoma will be seen with hepatitis C. For the T cell variety, I would like you to pay special attention to the terms that I mentioned. You will sometimes see the examiner using these terms interchangeably also. I mean, it might be written in the book mycosis fungoides / Sézary syndrome, but there's a technical difference. So the technical difference is like this. Mycosis fungoides is called as cutaneous T cell tumor. What is the presentation of this patient? He is gonna present with multiple eczematous lesions, and they're gonna be slowly progressing. So initially he is not gonna come to a physician, but this chap is seeing a, I would say, a dermatologist for a long time. But the lesions will keep on progressing to the level that now he will develop two very clinical, very striking, I would say, clinical presentations. One would be extreme redness all over his skin. Almost 90% of the skin of this patient will be having extreme amount of redness, that is erythroderma. Another feature will be that when you are going to check out the peripheral smear of this patient, initially the tumor was restricted in the skin, but now it's gonna disseminate in the bloodstream. So you're gonna see a T lymphocyte. Now obviously you will be seeing a lymphocyte. I mean, you can't pick up on a peripheral smear whether it's a T lymphocyte or a B lymphocyte unless and until you are a pathologist, right? So all you're gonna see is a lymphocyte. Characteristic of lymphocyte is mainly gonna be that the nucleus is gonna be very, very big, and I mean it will be occupying almost 90% of the entire cell. But you will notice a small constriction. I'll just put an arrow for this and zoom it in. You will notice a small constriction bang in the middle. I'm not saying that it's a bilobed cell. All I'm saying, it's a small constriction present bang in the middle. So this that I've shown before you is called as Sézary cell. This is itself a question. Sézary cells are found in, then answer is Sézary syndrome and not mycosis fungoides, though both would be given. Because what is happening is this Sézary cell, this is the malignant cell of this tumor that will now go and colonize the liver and the spleen, multiply liver and spleen, so hepatosplenomegaly. It can go to the bone marrow and can contribute to development of cytopenia. So this information that I'm putting in the box now, erythroderma, circulating Sézary cells, initially they have come from the skin, but now they're circulating in the bloodstream, will go and colonize and will contribute to development of hepatosplenomegaly. Bone marrow colonization would contribute to I mean, multiple cell lines getting affected. This description that I've given with respect to the box that I made, I'm just gonna mark it once again before you, is what is called as Sézary syndrome. So if I simplify things, I'll just say this Sézary syndrome is a disseminated form of mycosis fungoides. Mycosis fungoides is anyway easier for you to answer because the manifestations in pathology MCQs will just revolve around presence of Pottier's microabscess. So just like you guys are comfortable with Munro's microabscess for psoriasis, you guys are ultra cool with and remembering this term from pathology classes, Portier's microabscess. If a skin biopsy of this patient is done, and the dermatologist got this done because he was worried about the lesions are not improving. So when it comes to a T cell tumor, most of the time mycosis fungoides and Sézary syndrome might be written in an overlapping fashion, but I've tried to explain to you the disease originates in the skin and disseminates. Once it is disseminated, we call it a Sézary syndrome. Next, I'll be taking care of the international prognostic index for these patients. I have described this even in my discussion of Hodgkin's lymphoma, so keep a watch for slight difference that I say here. I'll take into consideration the age of the patient, LDH values, the stage of the disease, and the extranodal involvement. For extranodal involvement, I just want to state a MCQ from pathology. Like you're aware, the commonest extranodal involvement with respect to lymphoma would be the involvement of the GI tract, like of the stomach, because myeloma is the one that is basically trying to elicit from you. So if there's an extranodal site involvement, that's definitely to be mentioned. And then is ECOG, that's simply a Eastern Collaborative Group performance status. Now, what he means by this performance status is like you are having an old man diagnosed with non-Hodgkin's lymphoma, but because of his comorbidity, he could be having a cardiac problem because of which he has breathlessness on even going to the bathroom. On the other hand, you have an old man who's fit and fine and he says, okay, sir, I want to fight the disease. I will come to get chemotherapy regularly to your hospitals. So you can very well understand a person who's having, let me say, comorbid condition and cannot even go to the bathroom unassisted will be having a poorer prognosis than a relatively fit person. And based on this, I can calculate what are the survival chances, and I'll be starting this person on chemotherapy. R-CHOP was discussed even earlier for Hodgkin's lymphoma, but for which variety? The nodular lymphocytic predominant one. The drugs which are going to be discussed here is the anti-CD20 molecule, that is rituximab. Then is an alkylating agent, cyclophosphamide. Then for H, you know it from pharmacology, but do bear with me here, that is hydroxydonomycin. Then O would be standing for oncovin and P would be standing for prednisolone. So what I have done here before you is just quickly jot down the drugs which are going to be responsible here. And to finish this discussion, I have described 3 tumors where lymphadenopathy is the predominant presentation. Obviously, I mean, with respect to CLL, it would be a geriatric age patient. In Hodgkin's, it would be a younger patient. And then there are a couple of features like autoimmune hemolytic anemia, autoimmune thrombocytopenia. I have described autoimmune hemolytic anemia and thrombocytopenia even with respect to Hodgkin's lymphoma. But one of the classical features of Hodgkin's lymphoma is Bell-Epstein fever. So when you're going to pick up these keywords like smudge cells for CLL, Walder ring involvement for non-Hodgkin's lymphoma, Bell-Epstein fever for Hodgkin's lymphoma, written in any patient who's having a lymphadenopathy, and characteristics of whichever groups of lymph nodes that are involved. I mean, CLL and Hodgkin's lymphoma, it's mainly going to be cervical and mediastinal. In non-Hodgkin's, it's mainly going to be abdominal, unless until it's a African child where he's going to talk about a big jaw swelling and then again a cervical lymphadenopathy developing. And the investigational choice for CLL is flow cytometry, whereas the investigational choice for Hodgkin's and non-Hodgkin's is a excision lymph node biopsy. So these are the details that I want you to listen for this particular topic. And remember, I know there has been an overlap from pathology, so you're super confident of this topic, but I'm really proud of that super confidence that you're having, and keep learning new topics every day so that you keep on building to your knowledge. And as I say always, knowledge is power. That will help you go on to the other side, that is clearing the exam, and the life will be relatively more comfortable, because in doctor's life never stops, right? It's always gonna be a new thing coming up every day, new challenges, new competition, new things to be learned. Every day is a learning, I mean, every day is something that teaches you something new from a doctor's life perspective. So with these words, I finished this discussion. Thank you for your patience and hearing me right till the end.